Welcome back, still Daybreak Africa. If you're just tuned in, once again, happy independence celebration in Nigeria. This morning we shall be talking on Nigeria's health sector in focus as we discuss 64th independence. How has this health sector been faring from 1960 till date? Indeed, there's been lots of jackparing, there's been lots of inconsistency. But amidst that, are we really doing okay? Is the question. Are we really doing okay? Are we managing? Are we really at a point where we are getting it right, or we are actually losing it as a people? I'm with us in the house, as always when it comes to medical discussions, especially as this, we have our very own Dr. Olubusayo Modupe. He's a medical practitioner, Director of Health Insurance Scheme, State Specialist Hospital, Ondo, and Project Coordinator, HIV Program, State Specialist Hospital here in Ondo. Once again, happy independence, happy new month. Good morning to you. Welcome on the show, Doctor.
Good morning. Happy independence.
Good morning, Doctor. You're actually in the mood. This is your filler. It's something else. Like the Gen Z would say, it's giving.
I'm a Yoruba man. I decide to just dress like a Yoruba man
I know.
Celebrating our independence.
Yes, it's so nice to have you. It's been quite a journey on Daybreak Africa. You giving time, to take us through health topics, as it were. We appreciate you. But this morning, we want to talk something different, which is like Ezekiel has said, taking a look at the healthcare system in Nigeria. And since this is the season of celebration, independence, we want to go a little bit back before we get to the middle, which is the present. And of course, definitely we'll talk about the future. So I just want an overview from you. The Nigerian healthcare sector, 1960, till date. What do you have to say?
Yeah. We thank God that Nigeria is 64 today. It started, when after independence, Nigeria probably inherited what was handed over. And so historically, I want to divide the years to, for example, the 60s to 70s. What happened in the health sector? Well, fresh from independence, so major thing needed was infrastructure. Hospitals were created, but most importantly, it was in the urban areas, not considering the rural areas. Around 75, first launch into what is happening in the rural area was done. That's primary health care. Now looking into that. Then that was the first launch, 1960s to 70s. 80s to 90s, a lot of military rule. Then there was economic crisis. And so less emphasis were made on health sector during the 80s, 90s. And of course, we know in 1988 there was health sector reform, but nothing special came out of that. Then in the 2000s, the main thing that happened was the healthcare financing. That was when the national health insurance came. That's 2005. And I even remember that was when we were talking about MDGs, Millennium Development Goals. Emphasis on maternal and infant mortality. That was the main thing that happened then. Then in 2010s, what happened? Well, new policies. We were now considering reproductive health, including family planning. Then non-communicable diseases. Now talking about the hypertension, the diabetes, the cancers. And first introduction to what we call the universal health. Then we are in the 2020s. What happened? I think the main the first thing that threw everybody off balance was COVID-19. We were not using it. It exposed a lot. How prepared are we as a country to emergencies? Of course, it was so glaring. We were not prepared for anything. Then again, introducing telemedicine. Telemedicine.
Tell us more about that.
Yes. Before now, before you see your doctor, you consult one-on-one. But during COVID-19, there was we were locked inside. What was it called that time?
Quarantined.
Yes, we were locked inside. We were not allowed to go out, and people were still able to speak with their doctors, make prescriptions as at when necessary. That was the beginning of telemedicine. There were clinics we run that probably you see your patients every month. Therefore, the first time it became clear that, do I really need to see this patient every month? We can see every 3 months if this patient is stable. That is a general overview of what we are. And currently, of course, the universal health, that all the citizens must have access to a facility that will assist them in maintaining good health. And that is what the National Health Insurance Agency is working on now. And that's a very brief from 1960
Indeed, you have. But let's take a little as to how spending tends to evolve. I know you said during the military regime period, there was less attention when it comes to healthcare sector. But just away from that, how has our spending been over the last 2 decades? How has it evolved?
The truth is this: national budget is expected, the amount for health should not be less than 15%. That is what is recommended. But of course, year in, year out, we do extremely lower than is recommended throughout. So funding. So if we want to talk about the main challenge of the health sector today, cutting across from 1960 to date, is still funding.
Now, just adding to what Ezekiel has said, I got something here. It says Nigeria spent 72% of its health sector budgets to pay salaries and run offices in the past 15 years. Data from the Budget Office of the Federation shows that the federal government allocated 3.5 trillion naira to the sector within that period. It's really not encouraging. The fact that we have statistics that say salaries or the budget is more concerned with paying salaries and, of course, run offices instead of, its investment on humans, as it were.
Yeah, and that's a challenge. That's one of the challenges we have. You know, the health sector as a whole, it involves policies, infrastructure, and services. Policy, health policy, the infrastructures, and services. If any of this is missing, then there will be challenges with the health sector. And that is the problem we have. Policy, year in, year out, policies are being formulated. It's another thing about formulating, is another thing following it to the letters. Infrastructure. Are we doing enough as regards infrastructures? No. And part of the infrastructures, of course, what we have. This is an hospital. Is it accessible? Is it affordable? Are the resources, both human, everything, are they up to date? Part of the infrastructure, the health resources for health, the resources, the staff, is just part of it.
Not all of it.
Is not all of it. Again, even if you do that, paying almost 75% more for salary and running. What is the total percentage of the budget spent on health? I said the recommended is 15%. I'm not sure we do up to 3 or 4%. And so with that gamut of things to do, of course the only thing that appears so reasonable is picking the health resources, the staff, to pay their salary. Because if you need like 10,000 and it's only 1,000 you make available. If you need 10,000 for the health sector, you need for policy, for services, for infrastructure, and you're only making available 1,000. What does it mean? Then okay, let's just pay salary so that at least people will get at least keep it going. That's what is happening.
More of input rather than output.
Yeah.
So that's another statistics that we have, that the healthcare sector, the healthcare system in Nigeria is focused more on input rather than output.
Yeah.
So that's a lot indeed.
You know, when it comes to moving a sector forward, you can't do that without having alliance, without having partnership, investment, if I use that word. But I guess in medical word, should I say cooperation per se. So what role has international cooperation tend to play thus far when it comes to alliance with our sector, with our system, to make us better over time?
Especially for public health challenges. I think Nigeria has been majorly dependent on donors.
Okay. You make this sound like a bad thing. The way you said donors, you took a deep breath. More like, it's terrible, we're depending on donors.
We should they should support something. You are doing something, they are supporting you in doing it. If we talk about HIV, AIDS, donor-driven. You talk about TB, donor-driven. Mention COVID-19. When we were talking about
measles and mpox.
Mpox, everything is donor-driven. And so that's the challenge. You know, for example, because I do a lot of HIV, listen, government of America decides on what you should do with their fund. They are the one providing. So they decide what you should do with the funds. You don't have a say on it. Yes, there was a time at the beginning of the HIV program that a lot of tests were included, like testing the kidney function was included in the package of care for HIV patients. But at the time they stopped.
Why did this happen? When you say they stopped, are you talking about
the donors?
The donors. Why?
Yes.
Why? What
they
are the
decide,
reasons?
They decide where they want to put their money.
Okay.
I'm not saying. But if donors decide to stop, but is this test important? It's important. Then government of Nigeria should support that program with the test. That is
talking about continuation.
Yes.
So what has been the statistics? Are you saying at the point where the donors stopped, the federal government of Nigeria too stopped? Is that what we have?
What happens currently is that it's where your interest is that you spend your money on.
True.
It's simple.
Now, talking about donors, and we're reflecting now, we're talking 1960 till date. Has it always been this way? Where Nigeria, do we have a history of overdependence on donors for everything? Is this part of the history that we have, 1960 till date?
Yes. Although earlier, we tried to make sure we are able to stand on our own, do some things. I think everything became terrible during the economic challenges we have, most importantly during the military rule. And I'm not sure we ever recovered, even when civilian.
Now there's something that piques me. There's something that is that worries me when you talk about or you think about where we're coming from as a people. I was reading an article some time ago, and I discovered that people came from Saudi Arabia to UCH Ibadan for medical care, all the way from Saudi Arabia. This is something I read. I did not research. I actually read it, and it spoiled my day just thinking about it. That once upon a time, UCH Ibadan was like the Mayo Clinic, one of the best clinics or hospital in the world, not just in Africa, where you have people come out to have their medical care here. What happened?
The small state specialist hospital.
Yes,
where I work.
Oh my God.
We had expatriates working there.
Once upon a time.
I'm not even talking about UCH. That becomes almost something that you cannot even believe. Imagine now. Then from independence, we wanted to stand on our own. We were doing everything possible as the giant of Africa. Everything was working as planned. Health sector, all the sector of the country was being given the right perspective. Funding was top-notch. Our economy was also doing extremely well. And so it is easy for the infrastructures, if you want to make purchases for equipment, there's oil money that we were spending appropriately. And so people will readily, because everything that is supposed to be in a standard hospital was available in UCH. Why can't you come there? And of course, you know you will not be kidnapped on the way before you get to UCH. So the focus of government then was to make everything perfect.
So what happened to the focus? How did it get jettisoned?
I think we started to lose the focus from the military era. You know, military rule with decrees. What concerns a military man, with all what we are saying, what concerns a military man is how I will probably perpetrate myself in power. And of course, we had a very long military rule.
Can you say the challenge we face today in the health sector, is it comparable to challenge in the early 1960s? Say the first 20 years or the first 30 years and the later 30 years comparable? Do you think challenges, how comparable it is? How comparable is it actually?
The challenges now is massive.
Comparable to early
yes,
1960s.
There's no area of comparison.
Is it more like because now we have COVID-19, we have Marburg, we have Ebola, so it's all
we are just talking about the public health issues. Not everything is public health.
Okay.
Then probably we are not aware of all even if those diseases were even available, then the science would not even know that it's COVID-19. The science will not understand that, yes. But there are some simple things, normal things. Get to the hospital. A doctor is readily available. A doctor that is not overworked. A doctor that is not afraid that he will be kidnapped on his way home. Will see you, will make prescription. You are able to get to the pharmacy, get your drug that you are able to afford, and go back to your house. That was all happening then. Simple.
Interesting. We're still coming back to the discussion. We'll continue on that line because, you know, one or two questions just popped up in my mind. But we need to take a break like we do on the show for tea, water, or coffee. This is where we go straight on to go start business. Yes, it is time for us. The partying is enough. You have to look for money. And this is where we teach you how to make extra on the side on Go Start. And this is our special on the 65th or 64th, we'll see it. We'll see 65 definitely. 64th Independence Celebration going on right now. So sit back, relax, we'll be right back. You're still watching Daybreak Africa, Independence Special on Health this morning. Our doctor is still here, Dr. Modupe, looking all regal. Okay, before the break, you were actually responding to a question asked by Ezekiel, and I just want to continue from there. I remember growing up in Benin, where when you're ill, you just take a transport, or anyhow you want to get to the hospital, and you walk straight into UBTH Benin, and you get doctors to attend to you. I remember having the first and only time I really was admitted for a medical emergency. I more or less walked in there not even knowing what the problem was. I had thrombosis. As a girl of 16 years, I had thrombosis. I was escorted by my younger brother. And Dr. Momo, I don't even know where you are right now, just saw me, and the next thing, doctors were rushing all over me. They got a wheelchair. I was wheeled into the ward and admitted immediately. They took my phone number, called my parents to let them know I've been admitted, because what they thought was just simple leg pain was a thrombosis. And that was what happened. There was no bottleneck, there was no bribing, there was no limitation. They saw a little girl who needed help, and that was it. That was it. So we're talking years. I'm 16. I'm almost 100 years old now. So you can imagine how long ago I'm talking about. Do we still have such happen in our federal or hospitals, or can that still pertain in this time?
Naturally, emergencies should be taken as emergencies. But the truth of the matter is, it's not often like that currently. This morning, before I came, a colleague, yes, junior, called me. A woman delivered premature. So the baby needs neonatal care. We had to refer to a place that the little baby can have incubator care, neonatal care. I was called back. The woman came back with the baby, that the money they asked her to pay, she can't afford it.
And so they let her go with a baby who needed that care just because of some extra nairas to balance up what she has.
No, but the truth of the matter is, the hospitals too need money to run.
But you admit first, then you take what you have, then ask the parents to go look for the balance.
Well,
instead of putting the life of the child at risk, and of course
I'm
the
just
emotional.
talking
I understand.
generally the
responding,
kind of,
yes,
now,
to what I said.
Yes, those
really
are the
terrible
challenges we have now. Accident victim. Either you have relative, you don't have relative. They know you, they don't know you. You should be treated. Minimum for the next 48 hours, 72 hours. At least by this time, somebody,
the first aid has been done.
Somebody will come
appear.
Looking for you.
But the case is different now.
Yes, it's not like as before. And again, experienced hands have left this system for greener pastures.
You're just taking us to Japa now.
It's the same thing. So those are the challenges we have. There are so much challenge, a lot. And you know, the challenges is just intertwining. Health, economy, everything is just coming together. You talk about challenge in economy, you notice it will have its way back to health. That's where we are.
Can you discuss the impact of the primary health care under one roof? Do you remember that scheme?
Yes. And that's the principle now of that's why we are now talking more about the universal health. We want to provide health for everybody, and which is being championed now in Nigeria majorly by the National Health Insurance Agency. Thinking, you know, every community, in fact there's a distance, there should be a primary health center in every community. You don't need to travel before you get to that primary health center. This area where the studio is, there should be a primary health center with appropriate referrals. They are primary care, health care provider, they are secondary. So for what they cannot handle, they refer to a secondary facility. For what secondary facility cannot handle, they refer to tertiary facility. We have some good policies, but are we following it through? That's another challenge.
Now talking about primary, secondary, tertiary, I came across an organizational pyramid of the Nigerian health services structure. Administrative levels, we have the federal government. Under that, we have the state government, and under that, we have local government to private. Yeah. Then the service structure, we have the tertiary health services. Under that, we have the secondary health services. Then, of course, the primary health services, which trickles down to the private services. Then, persons in charge. We have for the federal and the tertiary, we have the Federal Ministry of Health. For the state government and secondary health services, we have the State Ministry of Health. For the local government and primary health, we have the local government areas. And of course, for the private sector, we have private providers. Now, in this pyramid that we have, we're talking 1960 till date. Can you take us on a little journey again, like you did when we started the show, on how we are fed or where we are at right now, from the administrative to the service structure to people or persons in charge?
You know, right from beginning, we have this local government, which is a tier of government, state government, and the federal government. All federal hospitals are directly under the federal government. All state hospitals are under the state government. And all primary health care are directly under the local government. That has been since 1975. That was when PAC started. That has been the arrangement. Now, even the federal government is not only tertiary now, because they also have some specialist clinic, which can be both secondary and tertiary. Even state governments now have both secondary and tertiary. For example, there's a teaching hospital in Ondo State. That's a tertiary service, but it's under the state government. Now again, because of the inactivity of the primary health care, currently there's even a national primary health care development agency that tries to oversee activities in the primary health care centers. In fact, there's also a state agency also overseeing what is happening at the primary health care centers. But the truth of the matter is, the primary health care centers are supposed to be directly under the purview of the local government. But mind you, you know what is happening in the country. We are talking about what do they call it for local government now? Autonomy. There's no autonomy. They can't do anything. Do you know that in most local governments, no matter the number of health centers they have, most local governments have just one doctor.
Just one?
Most.
Why?
And you know what? That doctor is, they call it PAC coordinator.
What does that mean?
Primary health care coordinator.
Okay.
It's more of an admin
rather than
yes, occasionally, because if, for example, in a local government you have 20 health centers, how will you run the clinics? How will you go around this place?
For just one?
One. Well, probably now we have people with two, three, but it's not adequate.
Now let's jump from what we're saying now to what you mentioned earlier when we talked about this Jackpot syndrome thing. Statistics has shown that in the past 5 years, about 15 to 16,000 medical doctors have left the shores of Nigeria. This is a huge problem. As we speak right now, there are doctors with their bag right at the airport, traveling out of this country in the search of greener pastures. When we started the show, I said I was going to use it as an opportunity to ask, this Jackpot syndrome, is this something that is new, or it has always been a problem in our health history before now?
Yes, sometimes, I think in the 80s, a lot of Nigerian doctors left for Saudi. But when, probably after the military rule, a lot came back. And for some time, we've been coping. Doctors and all other health workers, they've been coping. But in recent time, it became again pronounced. And that's why currently, even what happened then is a child's play to what is
going on now.
I'm not sure there is a day in Nigeria currently that a doctor or a nurse, somebody is not resigning
to leave.
I'm not sure.
How do we put a stop to this Jackpot syndrome? That smile, was it a smirk or a smile? Was it a ridicule or what?
No,
how do we know? Seriously, you're a Nigerian, I am.
Yeah.
We're celebrating 64 years independence. And we pray to celebrate more years, in health. But how do we do that when our doctors are jetting out of the nation? This brings in the place of the federal government, the responsibility of the federal government. We've not directly involved the federal government in our discourse, and we're bringing it in now. How important is it for something to be done, a change to happen in the health sector to breach or stop this movement?
We must understand, why are people leaving the country?
That's the question.
The first thing is greener pastures.
It's green here. There's
you
no
want
place
somebody
that's green.
You want something
look
greener.
Look at the flag. Look at what you're wearing.
You want something.
The land is green. Nigeria is green.
Yeah. So that's one. Then two, for fulfillment. Then three, are you safe where you work and where you practice? Three main reasons why people. An uncle of mine spoke with me very recently. He said, what are you doing in that our country? What are you still doing in that
so
country?
What answer did you give?
I just smiled.
Yeah, like you did before we started.
Yes. Because the truth is this. Am I safe where I work? Very recently, somebody close to my family, a doctor, was going to work in one of the north central states, was going to work in the morning, 8 a.m. She was kidnapped. It's not night. It's 8 a.m.
in the morning,
going to work.
To serve.
And so if tomorrow she was with the captor, I think for more than a week.
She's been released, right?
Yes. Thank God for that.
Thank God.
But something
came out.
Is she secured? She has her husband. She asks her children, will they be happy? If there's an opportunity for her to leave, won't she leave? Where you can, even if it's 12 midnight, you can drive anywhere and nobody.
Now, doctor, I hope what I'm going to say will come out the right way. We're talking about greener pastures. We're talking about security. Are we saying that the grass is actually green over where Nigerians are running to? And are we saying security is guaranteed wherever they are going?
In the UK, how many times have you heard that a doctor was kidnapped on his way to work? Nigerians are not lazy. We are not running away from work. In fact, Nigerians are hardworking. Outside the country, if you work, you are paid for the work you do. And it's commensurate with what we are doing. So if I decide to work 6 hours and you decide to work 10 hours, and we both will be paid according to what you work, the hours you work. Yeah, if you work, we are so hard working, you work 10 hours, and somebody work for 2 hours, you are going to be paid the same thing. Then when you equate what others are earning with what we are earning, then you know there's no pasture at all in Nigeria. It's not about green. There's no pasture.
Oh, but you're here. Why are you here? Why are you still here? Because a lot of people ask that question, and I'm asking you, I'm putting you on the spot right here on national or international TV. As a medical doctor, why are you still here?
And I will respond this way. Just like Jesus said, today you are seeing me. I can't talk about tomorrow.
Oh my, that's interesting. Ezekiel, you've been so silent. I want you to come in here now because doctor has gone religious.
Actually, he has been saying this over time. He's been saying today we see him, but tomorrow it's more like the Egyptian we see today, we shall see them no more. You did spoke about primary health care under one roof. Yeah. I would like to hear your view as to the Basic Healthcare Provision Fund, how it has contributed to healthcare development in Nigeria.
Again, you know what we are talking about. This it's something I'm very interested. The basic health, BCPF, it's for the vulnerable in our environment. I'm happy to tell you it is working. I have people from the hospital here that they have benefited tremendously from that fund. Once they are registered, they just bring themselves to the hospital. All care will be handled by the hospital, including difficult surgeries. So that's working.
Okay.
And I talked about universal health coverage. Yes, that's the main thing. And being midwife currently by the National Health Insurance Agency, they are working. And that's why where we need to go to healthcare financing is health insurance.
Now, this basic health that Ezekiel just mentioned, who are the people that are entitled to it? Can I apply for?
You are not really vulnerable.
Really?
You are not vulnerable, but you can benefit from health insurance.
How does that work?
Health insurance, you pay a premium, just like car insurance. They are different. They call them HMOs, health maintenance organizations. They are different ones. KAFTAN can register. Everybody, all staff can become beneficiaries. So that means because you may not always have cash in your pocket.
For emergencies.
Yes. And it will continue. In US, it has health insurance. In UK, it's NHS. That's what everybody keeps saying. Because it might be very difficult to always have cash with you. But already you have paid a premium for the year. So if you have complaint, you walk to your accredited hospital, you get treated, you go back home.
I think we need to create time to talk about health insurance on the show to educate Nigerians. It's something that keeps playing like a record at the background, but a lot of people, including myself, do not really have the full details, and I think we need to educate Nigerians, especially in this period of hardship. So if we can take health out of it, then we can focus on food, as it were. So we'll create time so we can educate the viewer for. So because of time, we need to talk about traditional healing. We need to talk about NAFDAC. We need to talk about power. In the sector, and of course faith-based. I was shocked when I was doing this research and I stumbled on faith-based healing. So I don't know where you were, because we talked about vaccine donors, we depend, then you talked about healthcare reform. I don't know where should we talk healthcare reform first before we begin to talk about traditional healing? Where we're coming with traditional healing, and let's talk about traditional healing and faith-based healing, this period.
Yes, there are a lot of things, traditional healings. They all abound. They are common. In fact, some have even so modernized that they are on radios, they are on TVs, advertising. But some of the challenge people like us have with traditional healers is this. For every of the diseases we have identified, I'm talking about the orthodox medicine now, is that there are no, we call it pathophysiology, their pathways are different. For example, fibroid is in the womb. And so if someone tells me, I will give you something and will pass the fibroid with stool, it's surprising to me, because where the stool will take is different from where the fibroid is. Or you tell me I have something that will cure diabetes, that will cure hypertension, that will cure peptic ulcer disease. I will pause. How can that be? Problem of diabetes is either relative or lack of insulin. That is not the problem in hypertension. And that's not the problem in peptic ulcer disease. How will this, your drug, cure everything? That's the challenge.
We don't have time.
Yeah.
I will just want your final take, your final say, this independence period as we round up on our discussion this morning. Your independence speech.
Okay. I think two things. Appeal to government. One, to take health sector as an important part, something very important, because it cuts across everybody, including them. Remember during COVID-19, when nobody can travel out, may we not have something like that again. So they should take health sector as very, very important. Then secondly, for the citizens, if our government don't like us, in quote, we must like ourselves. When you have a challenge, go to where you can quickly find help. And one of the simple ways is to register for health insurance. Thank you.
Thank you, Dr. Olubusayo Modupe. We appreciate you for being on our special Independence Health Package today on Daybreak Africa. Thanks for all the advice and, of course, your insight on the topic.
We shall be here tomorrow morning as we discuss another important topic as it affects Nigeria and most definitely the way forward. Don't you think so?
Yes, the way forward is the only way from where we are standing. Someone once said that there's only one way to stand and be static, and 1,000,000,001 ways to move forward. And moving forward is what we desire as Nigerians, not only in the health sector, but every facet of society, every part of our lives, and that's our desire. My name is Anire Binitie. Like Ezekiel said, see you tomorrow. Enjoy.
Yes, there is news on your device, but hearing an analyst's perspective is the icing on the cake that Daybreak Africa provides. Start your day with prompt analysis of the latest news, trends.
Exactly, and then you see these people, they are so agile, they can do a lot of
Politics.
We have to go back to that regional system. That is the foundation of this country, for God's sake.
Entertainment. Fashion. Culinary skills.
So first I'm going to be pouring the oil inside the pot, and I will...
Religious and cultural events amongst others on Daybreak Africa.
For a rich mix of analysis on current issues, tune in daily from 7 a.m. to 9 a.m. on channel 480 and 124 on Startimes.